Hi, my name is Sarah Christopherson, and I am the Policy Advocacy Director for the National Women's Health Network, and I work on federal policy and issues for Raising Women's Voices, which is a joint campaign between the NWHN, the Women's Health Program at Community Catalyst, and the Black Women's Health Imperative. Today is the 11th anniversary of the signing of the Affordable Care Act. So I wanted to record for our members a little bit of this ACA 101 presentation that I have been teaching college kids around the DC area for a couple of years now. It gives everybody just a very high level overview of what the Affordable Care Act, aka Obamacare, actually is and what it's meant for women's health. Quickly, a little bit about me. I have been with the National Women's Health Network for over 5 years, and prior to that, I was a congressional staffer. So I worked for the U.S. House of Representatives for 2 members of Congress. I was the legislative director when we passed the Affordable Care Act, and I kind of lived through all of those fights on the inside, and then I lived through all of the fights to defend and implement the ACA on the outside as a women's health activist. So that's a little bit about me. This is going to be, as I said, very top level. So there are going to be a handful of things that, as I try to cram as much information into this short overview as I possibly can, I may take a more simplified form. So there may be folks who say, well, wait, it's more complicated than that. Yes, it is definitely a little more complicated than I'm going to describe. So this will be a little bit like when your teacher told you couldn't subtract big numbers from small numbers, and then you find out that actually you can. It's more complicated. But there is just so much to cover, and we're going to try and do it really quickly. So the first thing that I like to make sure that when I'm talking to people who may or may not be as deeply into the weeds on healthcare reform issues is just to do some level setting so that we all know what the same terms are. And some of these folks, pretty obvious, right? So premiums. Let's start with those terms right at the top. And I'll just caution, my slides are very text heavy for this presentation. When I'm teaching college students, I give them a copy of the slides for our purposes. If I go over anything too fast, people can always pause the video, and you can always actually shoot me an email. My contact information is on that first slide. But so quickly, terms. Okay, so premiums. Premiums are what you would pay every month to keep and maintain your health insurance. So sometimes I compare it to rent, right? It's what you pay every month to make sure that you get that service. Deductibles are what you might have to pay out of pocket before your service kicks in. So let's say you have $1,000 deductible. So that means that you would need to pay down $1,000 worth of healthcare services before it kicks in. And then the last one is copays, which is what you would be paying out of pocket every time you go to a visit. So let's say you get sick and you need to go to the emergency room. You might have a $100 copay to visit the emergency room, or a $50 copay to visit urgent care. That's what you'd be paying out of pocket every time. So the other terms that I want to very quickly sort of talk about is there are sort of 3 big buckets of ways to think about kinds of health coverage. And so in this debate around the ACA, a lot of terms get thrown out that aren't actually tied to what they really mean. So sometimes you hear opponents of the Affordable Care Act talk about socialized medicine, and they mean that as kind of a boogeyman. But that actually has sort of a very concrete term. So I've laid out a little bit here. And again, as I said, this is the simplified version. But in the first of our big 3 buckets, the government owns and operates the healthcare facilities and employs the healthcare professionals. So you walk into a government-run clinic, the doctor is paid by, salaried employee paid by the government, and what we think of as health insurance is covered all within that government package. And the famous example people think of internationally, the National Health Service in the United Kingdom. And we actually have versions of this in the United States too. In fact, we have versions in the United States of all 3 buckets that I'm going to talk about. So in the United States, we've got Department of Defense, Veteran Affairs, and Indian Health Services, right? Those are all examples where the government owns the hospital, the government runs the clinic, the government pays the doctors, the government provides all the services, the government pays for care. The next kind of big bucket would be what's sometimes called single payer. And this would be where The government is providing the health insurance, so the government is paying for the services, but the providers are all private practice. So you've got private doctors, private hospitals, private clinics, private nurses, and it's the government that's paying for that service. So famous international example, Canada, Canadian Medicare, but we also have versions here in the United States. And so one, the ones that folks may be familiar with, Medicare for seniors, Medicaid for low income, but I put a little asterisk there, and we're going to come back to that asterisk, and then TRICARE for military personnel. And then the last big kind of bucket of ways to do healthcare provision is through this multi-payer. And that is where both parts of the process are private. So then they may be subsidized by the government in various cases, but the operators are private. So you've got private facilities, private doctors, private clinics, and you've got private health insurances companies. Those health insurance companies can be for-profit or non-profit, but they're not run and managed by the government. And so in the United States, we have examples like health insurance that gets purchased through the individual market, health insurance that you might get through your employer. And then a famous international example would be Switzerland. And Switzerland is actually one of the examples that people looked at when they were creating the ACA, because it is this private to private system. The thing about these models is that you can actually get to the broader question of universal coverage, where everybody is covered with high quality, affordable, comprehensive health insurance through any one of these things. But it's just sort of what trade-offs you make and how you get there and how involved the government is. Is the government providing subsidies? So those are questions that the policymakers like to get into, but there's no sort of one right way necessarily to get there. There's all these different trade-offs. Okay, so now we've level set. Now we have some sort of understanding of what all the different terms are. I want to talk a little bit about the history of passing the Affordable Care Act. And this is personal for me because, as I mentioned, I was on the Hill. And so I was part of this fight, and I could see just sort of how much time we spent working on the Affordable Care Act through 2009 and 2010. The summer of all of the town halls where we were all sort of fighting about it extensively, the rise of the Tea Party movement. And there got to be this sort of talking point that the ACA was rushed through. And in fact, it was a very slow, very deliberative process. And so I have up on the screen this quote from John McCain, which he was said on the Senate floor in 2013, but it gives you some glimpse as to just sort of how detailed the ACA was in terms of its legislative process. So the Senate's Finance Committee, there were 564 amendments submitted, 135 amendments considered, 79 roll call votes, 41 amendments adopted. Then in the other committee, 500 amendments considered. And this is just on the Senate side, right? There was an equally long process on the House side, 160 Republican amendments accepted. And then it came to the floor. And it was on the floor for 25 straight days, including weekends between Thanksgiving and Christmas. Hundreds of amendments, hundreds of Republican amendments, dozens of roll call votes. So that gives you a little bit about the process. So where we've got Christmas Eve, 2009. The Senate has gone through this lengthy process of considering the Affordable Care Act, passes it by 60 votes, right? And I've got this little graphic so you can see the Affordable Care Act is quite a significant law. It's very wide ranging, as we'll get into a little bit in the next few slides, but it's huge. It's a really big package that went through this long consideration process. But when Democrats in the Senate passed it by 60 votes, so they overcame a filibuster and they passed it, there was this understanding that the House would take the package that the House had passed and that the Senate would take the package that the Senate had passed, and they would come together and work out the details, right? There were a lot of things that I, as a House staffer and as a progressive who's interested in expanding healthcare, really preferred about the House version, but there were a lot of things that I liked about the Senate version. And so we were looking at this process of conferencing those two bills together and to make one best possible package. Except that a few months, in February, after the bill passes in Christmas, Then February, there's a special election in Massachusetts to fill the seat left by Ted Kennedy when he passes away, and Scott Brown wins. So all of a sudden, Democrats can no longer overcome the 60 vote threshold to overcome a filibuster. So now there's a scramble about what to do. And the takeaway, the sort of conclusion after several weeks of negotiation, was that the House would pass the Affordable Care Act as is, with no changes. So even though the House preferred its own version, and even though there were some significant problems with the Senate passed version, the House would take up the Senate passed version, pass it as is, and send it to the president. But they would use this process called reconciliation, which is not subject to a filibuster, so they did not need to get 60 votes. And they would pass a little package of fixes. And that's what my infographic here is at the bottom, that little package of fixes that they could get through the reconciliation process to sort of harmonize just a tiny bit the big Affordable Care Act passed by the Senate with some of the House's preferred mechanisms. So that's what we ended up with. We ended up with the Affordable Care Act passed by 60 votes, and then this much smaller package of reconciliation fixes. And actually part of that reconciliation package was related to unrelated student loan issues. And then we, at the legislative level, kind of got stuck, right? So in 2010, Republicans win back control of the House. That really prevented Congress from doing what Congress would normally do. So every time Congress has passed major expansions or major programs of any kind, really, but if you look to at the big expansion in Medicare in the early Bush years, right? Anytime there's this big package that Congress passes, they are constantly sort of refining in that process afterwards, what worked, what didn't work, making technical fixes. And because of the ideological opposition to Obamacare, that process kind of stopped. So we really had a long period of just sort of legislative blockage on the ability to fix, you know, the normal kinds of problems that arise in these big sort of packages. The exciting thing about me being able to talk to you today is that for the first time, we, through the Biden COVID relief package that was just passed, and that I'll talk about a little bit later, have actually made some pretty significant improvements in the ACA. So it's sort of an exciting time to be talking about the ACA after so long of kind of a legislative stall. The other reason why this is sort of relevant is that there's just a limit to what you can do through reconciliation. And we actually saw that a little bit in the COVID relief package that was just passed, right? There were provisions that progressives had hoped to do through reconciliation that the Senate parliamentarians said, no, can't do. And one of them was minimum wage, but there were a handful of others where the Senate parliamentarian says, given that the rules of reconciliation, which again is this little tool, this procedural tool that lets you get beyond the filibuster or bypass the filibuster, excuse me, that the rules are so narrow that not everything qualifies. And so this visual of the big Affordable Care Act versus the small reconciliation package of fixes in 2010 should kind of indicate the limitations of reconciliation. And so as progressives are looking for going forward, how to continue to build on expanding universal coverage, how to tackle questions like immigrant coverage, how to tackle questions like the Hyde Amendment that limits abortion coverage, these are not things that are likely to be able to be done through reconciliation because the rules are so narrow, which means that either people who support advancing healthcare are going to need to win 60 seats in the Senate, or they're going to need to think about filibuster reform. They're going to need to think about eliminating that tool that prevents the majority from making necessary changes. We won't get into all of that right now because I want to talk about what's in the ACA. So I like to think about the Affordable Care Act and split it up into two big tracks. And the first of those sort of tracks is that the ACA improved coverage for everybody, including those who already had employer-sponsored coverage. And this is where I sort of whisper, you probably have Obamacare, because during the fight for ACA repeal, a lot of folks would say, why should I care? This doesn't affect me. I don't have Obamacare. And in fact, the ACA was so wide-ranging that it really impacted, everybody, basically. So let me just walk through a handful of the ways that the ACA improved coverage. So in the bad old days, there were, and I'm right here in this first bullet point, there were caps on your benefits. There were annual and lifetime caps on benefits. And so what that could mean is that you could burn, if you got very sick, if you were in an accident, you could very quickly burn through your entire, lifetime or annual cap on coverage. And the example I like to use is a prematurely born infant in the NICU who might leave the hospital at 2 or 3 months old, having already used up his or her entire lifetime cap with that insurance plan. Under the Affordable Care Act, no more annual or lifetime caps on benefits. Second one, in the bad old days, you could be discriminated against on the basis of pre-existing conditions, and sex, including gender identity, was a pre-existing condition. And so you'd have these really sort of ridiculous scenarios where a 40-year-old woman who didn't smoke would be charged significantly more than a 40-year-old man who did, solely based on her sex. And it also led to discrimination based on things like rape or domestic violence, history of having a C-section. All of these things would be excuses to charge you more. And that actually started to have an impact too on hiring decisions. So imagine that you're a small employer who is going to bring on a candidate who will then impact your insurance premiums. It was cheaper to hire men because it wouldn't boost the premiums for the employer plan. So now, under the ACA, there is no more discrimination based on pre-existing conditions, no more discrimination based on sex. Third, cracking down on rescissions. That is, rescissions are canceling policies when people get sick. And so in the bad old days, you would have health insurance companies employ teams of people whose job it was to go through the policy, go through your medical history when you got sick, and see if there was any T you hadn't crossed, any I you hadn't dotted, and they could use that as an excuse to cancel your policy the second you got sick. So let's say you're paying your premiums every month on time, and you've always been healthy, so you've been the ideal health insurance patient. But then you get sick or you're in an accident, and all of a sudden you become very expensive. You get a cancer diagnosis. So the insurance company would pay someone to go through and see if there was anything that you had left off of your paperwork when you filed. And, some of the examples are really just extreme. So you might have had acne when you were 12 and you didn't think to report that to the insurance company when you signed up for a policy. Well, they could use that as an excuse that you had a pre-existing condition you didn't report and cancel your policy. And that sounds ridiculous, and yet that is exactly what was happening. So under the Affordable Care Act, no more canceling policies when people get sick, no more rescissions. In the bad old days, there was no limit on out-of-pocket expenses. So anytime, you could just keep spending and spending. Right now, under the Affordable Care Act, there is a cap. Now, the cap could arguably be lower. I would argue it could be lower, but there is a cap on out-of-pocket expenses. The next one is kind of big, which is requiring plans to cover basic essential health benefits. So prescriptions, mental health care, emergency room services, maternity care, or meet a minimum value standard. So good coverage across all of those. And this ended up being somewhat controversial, which is how you had Republican men going to the House floor and arguing that they can't get pregnant, and so why should they have to cover maternity care for others? Well, maternity care is a particularly funny example in my mind for people to use because there are no human beings grown in sci-fi capsules or pods, right? Every human being had a maternal parent that required or could have benefited from maternity care. There is not a human being alive who somehow skipped the pregnancy phase. So the other thing that's funny about maternity care, of course, is that there is not a human being alive who is not the result of sperm and an egg joining. So just looking at those factors, it makes sense that maternity care be broadly covered. But specifically, you know, I don't have a prostate and I will never need prostate cancer. But if I will never get prostate cancer. But if I pay a little slice of my premium, just a tiny, tiny slice of my premium to cover someone else's prostate cancer coverage, and they pay just a little slice of their premium to cover my maternity care, it ends up being significantly cheaper for both of us. It really smooths those costs out for both of us. Whereas if only the people who got prostate cancer covered prostate cancer care, and only the people who were planning to get pregnant had maternity care, it'd get really expensive really fast. There'd be no smoothing out. So we call this risk sharing. I cover a little bit of you cover a little bit of mine, and it's much cheaper for both of us. The next thing that the Affordable Care Act did was make preventative care, so checkups, vaccines, contraception, cancer screening, free from copays or additional costs. So remember, we talked earlier about deductibles and copays. What this means is you go in for your annual well exam, or you go in for your birth control, you go in for your mammogram. These things are covered without you having to pay out of pocket. And that's actually a really big deal. There have been a number of studies that showed that having what they call cost sharing, but making people pay out of pocket for preventative care really discourages them from getting preventative care, even though it's cheaper for everyone, better over the long run. So the last one, or not the last one, the second to last one, requiring plans to cover dependents up to age 26. And then the last one isn't talked about publicly that much, but it's actually really important, I think, which is that it requires insurance companies to spend a portion of their premium, a high portion of their premiums on healthcare. This provision is called the medical loss ratio. And I've got 80 to 85% because it's sort of the difference is whether you're covering the small group like individuals and small employers, or whether you're covering big employers. But the idea being that if you are paying your premiums into an insurance company, the insurance company has to actually use all those premiums collected to provide care. They can't jack up premiums and then take all the profits and use it to send themselves on fabulous vacations and, you know, boost CEO salary astronomically. They need to maintain at least some threshold, so they can only spend 15 to 20% of the premiums they bring in on their administrative expenses, including salaries. And that is one small but significant way that helps sort of keep costs down. So the underlying costs of care, the costs driven by providers or drug companies, those might still be rising, but the premiums that you're paying for your health insurance have to track to what that actual cost of care is. They can't just jack your premium way up to give themselves bonuses. They have to, and if they do, and they don't spend at least 80 to 85% of the premiums that they pull in back out on the patients that they cover, they have to give you a rebate. So it's pretty significant. So that's track one. That's sort of making it better for everybody. And I should clarify here that sometimes when I'm saying everyone, there are limitations on immigrant coverage of care. So there are, and we'll get into it a little bit, but there are limitations on undocumented people participating at all, and there are waiting periods for lawful permanent residents. So there are certain subsidies and certain help that people don't get to take advantage of. But I'm getting a little ahead of myself. So let's go to track two. So track two is to help people without insurance get quality coverage. And this is sort of divided into two parts. And so the first part is expand Medicaid to cover the most vulnerable people in America. And this, again, is where that caveat about immigrants really matters, because undocumented immigrants are not eligible. So original Medicaid, I said that we would talk about that little asterisk around Medicaid. Well, this is it. This is the asterisk. So original Medicaid is low income, and to qualify, you must be low income and pregnant, low income and disabled, low income and elderly. It's a categorical eligibility. You have to fit the category to be eligible. The federal government covers part of the cost and states cover the rest. But for a lot of people who didn't qualify, they don't meet one of these categories. And, so for example, you might be low income and pregnant, and you qualify for Medicaid, and then 60 days postpartum, when you aren't pregnant anymore, you lose your coverage again. So now you're a low income young mother with a 2-month-old, but you're not covered. So what the Affordable Care Act did was to expand Medicaid to everyone. So low income, no and. That's how I've got it on this slide. So it was open to everyone who met the income requirements and had legal status in the United States. And it came with an extra sort of benefit, which is that federal governments paid 90% of the costs of enrolling this population instead of the lower percent that the feds pay for Medicare and Original. So that's the first part. Expand Medicaid to everyone who's low income. And then for folks who are a little bit higher up the income scale, help those low and moderate income households buy private health insurance in the individual market. And so there are a handful of different ways that the federal government helped pay for that. One of them is a subsidy that helps them pay their monthly premiums. So you would get an automatic reduction in your premium that you pay every month, and the rest would be covered by the federal government. And then the other kind of subsidy would help keep copays and deductibles low. So you wouldn't be paying as much out of pocket even after you paid your premium. And then the other big thing that it did for this population is that each state's insurance market has, I call it Travelocity style or an Expedia style or hotels.com, whatever you prefer, that allows you to make comparison shopping between plans easier. And there's some grumbling about, the system could be better. And that's absolutely true. But I have to tell you, as someone who had to buy insurance in the individual market pre-ACA, that was sort of a nightmare. I was left to call this company, to call that company, to try and compare plans. It didn't make any sense. Now you can have a relatively straightforward comparison of how much a plan costs, how big the deductible is, what it actually covers, how much help you're going to get from the federal government, and you can make those kind of cost comparisons. So it's pretty significant. So that's sort of track 2, and this is my visual for what track 2 looks like. So you've got this big expansion, this big blue box on the bottom. So everyone who makes less than 138% of the federal poverty level. And if you want to know what that number is for 21, they've got this little chart over here. So let's say you're a one-person household, you're single, you make less than 138% of the federal poverty level. In 2021, that's just under $18,000 a year. That's your annual income. So you qualify for Medicaid expansion. And Medicaid is really popular. It covers a lot. It covers a lot more, actually, given how vulnerable this population is, than sort of regular private health insurance. So one example would be if you need help getting to and from appointments, Medicaid can help cover that. There are a handful of they call them wraparound benefits like that. And Medicaid is really popular. Folks who have Medicaid really, really like it. And then, so for folks a little higher up the chain, so maybe making a little more than $17,000, $18,000 this year, they get subsidies to help them buy private health insurance. And those subsidies taper off when you get to 400% of the federal poverty level. So let's say, again, you're a one-person household. So by the time you were making $51,000, you would not be getting any support from the federal government. And, you know, these are the sort of thresholds for across the 48 contiguous states. So you can imagine that a single person making $51,000 in a low cost area is got a very different sort of cost burden than someone living in a high cost area. So for some folks, having that taper off at 400% federal poverty level has made it unaffordable for them. But this is the ACA. So this is the ACA as passed. So here we have now on the left-hand side, the ACA as passed and as enacted in expansion states. But in 2012, as part of the big Supreme Court rulings that tackled whether or not the Affordable Care Act was constitutional, the Supreme Court upheld most of the ACA, and that was kind of the big headline rulings the ACA upheld. But they did something for Medicaid expansion, which was to make it optional for states. So instead of saying everyone who's income qualified is now eligible, instead they said it was up to individual states to decide. And that's where you end up with this very strange world where there are now because activists like us have been fighting for Medicaid expansion for a decade, you have most states and the District of Columbia who now operate like they're supposed to, right? That as envisioned by the ACA. But there are still 12 non-expansion states where people, and the numbers for non-expansion states are different, and it's not worth explaining why. It's a quirk of the law. For the non-expansion states, your ACA subsidy kicks in at 100% instead of 138. Just trust me on that one. But if you live in a non-expansion state and you fall into this area of the blue triangle, then you have expansion, or you have access to subsidies. But if you make less than 100% of the federal poverty level, you fall into this, and this SOL is a highly technical health policy term. You are shit out of luck if you live in a non-expansion state and you don't make 100% of the federal poverty level. So you can imagine it creates this really bizarre situation where people who are otherwise exactly the same but live on opposite sides of the border may have access to really great, comprehensive and affordable coverage, or no access to any coverage at all. And so it's one reason why we're really pushing the 12 states that remain to expand their coverage. But I want to stop and look a little bit at what those states look like. So here are the Medicaid expansion and non-expansion states. The 12 that remain. Wisconsin is included in this group. They have a little bit more of an expansion, but it doesn't qualify as the official expansion, and it's not nearly as comprehensive. So let's look at a little bit closer at these states. So this is a chart from the Kaiser Family Foundation that I updated for 2021 just to take into account who had expanded. And it's really important because it shows you this same map, right? This same map, you look at it and you can see that there are actually some bright red states that have expanded Medicaid. So even though there was this burst of ideological opposition to Medicaid expansion, you can see that states like Utah, Idaho, and I'm from Utah, so I can tell you we're a bright red state. States like that have slowly but surely started to expand. So it's no longer just a question of red versus blue, conservative versus progressive. There's something else going on here. And what you see is this slide that I moved forward to from Kaiser, which is that the states that have absolutely pushed back on expanding Medicaid are the states that form that old Confederacy, right? The Jim Crow states. It's not a perfect parallel. You have states like Wyoming, although interestingly, Wyoming just last night, their state legislature's House moved forward with the Medicaid expansion. So in some ways that sort of fits this dynamic where the kind of old Jim Crow states that have been so resistant to covering their Black population based on racism, right? At this point, that we can be pretty clear that racism is driving some of these remaining decisions. And we actually have an article that was written by my boss, it's fantastic, that goes into much more detail about it. So I've included the link below that just talks about why Medicaid expansion is so important for really tackling the vestiges of Jim Crow, right? All of the ways that states built their Medicaid programs to exclude Black people, to exclude other groups of color, and why Medicaid expansion under the ACA is absolutely critical for getting to health equity. So now that I've talked about that, I want to dive into a little bit what the Biden package, that the Biden-Harris Congressional Democratic package that just passed. A lot of focus has been on stimulus checks, and that's fantastic. There's been a lot of focus on the ways that the bill could eradicate child or reduce child poverty, direct supports, food assistance, vaccine funding. There's a lot, but I want to talk about what the bill does for the Affordable Care Act. So this is the chart that I showed you, the ACA as expanded. You've got your Medicaid block, and then you've got your blue triangle of subsidies. And this is what the COVID relief package does for the next 2 years. It makes those subsidies to purchase private health insurance significantly more generous, and it eliminates that cap at 400%. So it says that you never have to pay more than a certain percentage of your income, and then the feds will sort of pop in and cover the rest, which is a really big deal for a lot of those high-cost states that we talked about earlier, where low-income folks might be charged a lot, but because they are right near the top of that blue triangle, they weren't getting any help. So here we see a little bit about what that means for people. And these numbers come from the Center for Budget and Policy Priorities. So an individual making $18,000 would pay zero. Their premium would just drop to $54 a month. An individual making $30,000 would pay only $85 instead of $195, and so on. And so this is really huge. This could argue, well, experts who've looked at this and predicted that this could cover 4 to 5 million people, these kinds of expansions. And we've actually been pushing for this for kind of a long time. So, you know, there are absolutely ways to work within the Affordable Care Act to get closer to what universal coverage would be. So this has been really exciting. One other thing that the COVID now, let me back up a little bit. So this has been really exciting. We've been pushing for this for years, but it's short term. So it only covers 2021 and 2022, which means that a lot of people are going to have access to great subsidized, affordable, high quality care for the next 2 years. And then we're going to hit kind of a crisis where that expires, and all of a sudden those people are going to see their costs go way up again unless Congress takes action. And so that's one of the things that we need to push for, is for Congress to make these expansions of coverage permanent. We can do this. We can certainly afford to do this, and it is the way to get people covered. The other thing that the Affordable Care Act, the other thing that the COVID relief package does to build on the Affordable Care Act is provide some incentives, some financial incentives for those remaining 12 states, gives them some money, basically, to finally take the leap into expansion. Now, because the economics of expansion have always been good, it's not clear whether that alone will be enough to get some of those last hardcore states to expand. But it's exciting that this opportunity exists for activists who want to push forward. I'm going to pause there and take a little breath. So one more thing I want to talk about is kind of the future of the ACA. So I've talked about what the COVID relief package can do, and I've talked about what we need to be pushing for, in addition to sort of the other things that progressive advocates might be pushing for around single payer or other sort of exciting, very different proposals. Building on the ACA is a very important sort of near-term victory that will make a real difference in people's lives. But it's still at stake. The Affordable Care Act is still at risk through a lawsuit filed by state Republicans or Republican states. So I want to give you just a very quick overview of what the ACA, sort of like the big challenge to the ACA is right now in terms of the future. So we talked a little bit about the 2012 Supreme Court case, and I told you that the headline news was that the law was upheld as constitutional except for the Medicaid expansion was made optional. And one of the ways in which the law was upheld was that the ACA included an individual mandate, meaning a mandate for individuals to buy coverage, to get care. And if they didn't purchase health insurance and get covered, then they had to pay a tax. And the Supreme Court argued that because there was a lot of questions, we would argue that the individual mandate was constitutional regardless. But the Supreme Court cited that it was constitutional because it qualified as a tax. So flash forward to 2017. The GOP spends much of that first part of 2017 trying and failing to repeal the Affordable Care Act. They can't do it. But what they do successfully do is enact a massive tax bill, again through reconciliation, so they didn't have to overcome a filibuster. They could sidestep the filibuster. They enact a massive tax bill, but because of the rules of reconciliation, they could repeal the penalty. They could get rid of the tax, but they couldn't actually get rid of the mandate itself. So again, I said reconciliation really limits what you can do. So you could make things that have this direct budgetary impact, but you can't make policy changes. So they were able to to get rid of the tax, but leave the mandate technically in place. So technically right now, there is still a mandate to purchase health insurance. But if you fail to do so, exactly nothing happens. The IRS doesn't knock on your door. There's no black helicopters coming to get you. Nothing happens. So it's a toothless mandate. But in 2018, a handful of Republican state attorneys general got together and decided that they could use that as the crux of a lawsuit. That if the Affordable Care Act, if the individual mandate was only constitutional because it was a tax, and now there was no tax associated with it, then the individual mandate was unconstitutional, they argued. And then therefore, the entire rest of the law must fall. And I'm not a legal scholar, and I'm not going to get into all of why this case is ridiculous. But it has been widely panned even by conservatives. So even one of the conservative architects of the original ACA lawsuits in 2012 and 2014 has called this case bananas. The legal theory of this case just absolutely bananas. But we live in a world where even bananas cases can threaten the healthcare of millions of people. So where we stand right now is that the Supreme Court heard oral arguments at the end of 2020, and we are expecting them to decide the case at any time. And there's reason to be cautiously optimistic, based on what several of the justices said during oral arguments, based on the fact that most Republican officials don't necessarily want to deal with the chaos of having the entire ACA blown up and being blamed for all of the madness that would ensue. But you just never know. We never know. There are a handful of things Democrats could do. For instance, they could add a $1 tax penalty back in mooting the lawsuit. But right now, we don't know. We're sort of in this vulnerable position waiting for the Supreme Court. So that's sort of one big part of the future. And then the other part of the future is building on the ACA in ways that can't be done through reconciliation or can't. So you can expand subsidies through reconciliation, but you can't cover immigrants. You can't make policy changes through reconciliation. And that's what takes us back to the need to repeal the filibuster. So there's one last thing I like to talk about when we're looking at the future of healthcare reform, because there are questions and issues that we should be sort of tackling right now, even as we're moving more and more and more fighting for universal coverage. So three things that kind of come up in this Medicare for All conversation. The first one is, will abortion care and full birth control services be covered? And actually, also a number of services related to trans care and other services that have been really sort of stigmatized or demonized, right, as part of a culture war issue, but are truly part of healthcare. So right now, under federal law, thanks to the 4 decades old Hyde Amendment, most abortion services aren't covered in federal public health programs. Individual states can make their own decisions with their own state tax dollars, but the federal government doesn't cover abortion care. So if we move to a system of this, like a single payer system, where the federal government is providing all the health care, we have to sort of tackle this big political question of, are we going to embrace that abortion care is health care, that contraception is health care, that trans care is health care, and make sure that these services are all covered in a broad public health program. And then the other one that I've talked about a lot already is immigrants. So I mentioned earlier, under current law, lawfully present immigrants must wait 5 years. Undocumented immigrants are not eligible at all. And then the Trump administration had proposed, they had a public charge proposal that would have made coverage even harder. Now the Biden administration has said they're not going to enforce that. So that's a fantastic victory. But it goes to show what kinds of people might be left behind if we eliminated private health insurance and worked towards public health insurance. So for folks who want to make that move towards a more and more robust public health insurance system, there's value in kind of doing some of the work now around fixing inequities in our current public health system. And then the last big question, sort of for folks who are sort of thinking about Medicare for All or any of the various competing plans that would lead to a more robust public health insurance, is what about folks who currently have private health insurance, and even if they don't like it, they might be scared to lose it. So what options exist to sort of work within that? So that is a little bit about sort of the ACA, and also kind of a little bit of discussion about what we should be working on and thinking about in the next couple of years. So with that, I want to end there, and just for everyone who made it with me through all of these slides and all of this discussion, thank you so much. I really love working on Affordable Care Act. I really love working on Medicaid expansion. We've really appreciated all of your support as we have worked to expand healthcare to women over the last 5.5 years that I've been here. So thank you and good night.